Okay, good morning or good afternoon or good evening, everyone, depending on what time zone you're in, and welcome. Thank you so much for joining us today. My name is Dr. Sarah Murray, and I'm a faculty member at the Johns Hopkins Center for Global Mental Health at the Bloomberg School of Public Health. The Center for Global Mental Health works to advance equitable, accessible, and culturally responsive mental health care around the world through research, training, and partnerships. We're especially committed to strengthening community-based approaches and bridging gaps between evidence, practice, and policy. We're delighted to have you with us for our speaker series, Who is the Provider? This series explores a central question in global mental health: who provides care and in what contexts? From clinicians to community members, we've been aiming over the course of this series to highlight the diverse people and approaches shaping mental health support across cultures and systems. Each session, we aim to bring together practitioners, researchers, policymakers, and community leaders to spark learning, dialogue, and new ways of thinking about how care is delivered globally. Today, we are especially honored to be joined by Dr. Cyrus Mugo. Dr. Mugo is a senior research scientist at Kenyatta National Hospital in Kenya, with training in medicine, global health, epidemiology, and implementation science. His research over the last 15 years spans across the HIV care cascade for children, adolescents, and young adults, and included HIV testing, treatment, and treatment support. His current focus is on mental health care integration into routine HIV care, epidemiological and implementation science research on neurodevelopment, and the transition from pediatric to adult HIV care services. We're very excited to learn from his insights and experiences today. Before we begin, I do have to give you a few quick reminders. Please feel free to use the chat if you have reflections or questions throughout, and we will leave time for Q&A at the end of the session. But with that, it's my pleasure to welcome Dr. Cyrus Mugo, and I will turn it over to you.
Thanks so much, Sarah. I'll start the presentation. There you go. In last slide, maybe. Right. Thank you all so much. I'll turn my video off, but I have better network. I hope you can all hear me well.
You sound great.
Perfect. Yeah. So today I'll be presenting some of the work that we've been doing over the last three or so years. It was a little earlier, but the work started about 3 years ago. And I've titled this talk as Filling the Gap, co-designing, testing, and integrating task-shifted mental health services for adolescents and young and youth with HIV in Kenya. And credit to my team in Kenya in the PROACT study for helping me develop this intervention, Dr. Nelima, Dr. Vincent, and Sano, one of our research assistants. And brief about this presentation, will be on topic on who is the provider. We'll be discussing mostly the PROACT study and another allied study I'll show you briefly. And this is, a hybrid effectiveness implementation cluster randomized trial. I'm not going to talk so much about the design, but we're in 30 sites. It's one of the largest studies that have one of the largest trials I've had to the honor of implementing with a sample size of 600 adolescents and young people, and funded by the National Institute of Mental Health, 5-year grant R01 2023 to 2028, with multiple PIs, Dr. Dalton Amalwa, Dr. Pamela Collins, and so thinking about HIV and the mental health burden, I think this cannot be said as strongly as the papers already show. Very high burden of common mental disorders among adolescents and youth with HIV. About double the risk of adolescents and youth, and the baseline. This is still very, very high. talking about 25% to 40%, especially thinking about women who are pregnant or parenting. Those rates go very high, 50%. And this is not a small group. If you're thinking about Kenya, this is 250,000, adolescents and youth. They have their families. So this is a big, big population we're thinking about. And context in which we are talking about their mental health is in the HIV care setting, which is largely manned by non-specialists, lay cadres, and very constrained specialist services for mental health. This is the context we are in. And thinking ahead and trying to justify, hopefully to an audience that already accepts this, the task shifting could be acceptable enough as a strategy to provide essential care for. So mental health has a big price. There's a big price we pay for not addressing mental health challenges, and it's not just on the direct mortality. We have deaths uh, poor mental health, talk about suicides and so on, and related non-cardiovascular, communicable disease morbidity. Um, we do have specific HIV outcomes. For this population, this compounds it because we may not say that mortality or morbidity is necessarily due to the mental health problem, but we will see it in the poor viral suppression. We will see it in, the advanced HIV disease, the poor quality of life, the poor school performance, the higher mortality that we see in this group. And that is how it will manifest itself. We'll see it in the poor adherence, poor engagement in care. And thinking a little back on what are the risk factors, what really are we dealing with when we say that this group has higher poor mental health risk? It's higher poverty levels, higher exposure to violence, HIV stigma being a big for mental health. Talking about caregiving and parenting for these young people who very high rates of orphanhood, up to 40%. That's what we're seeing in the cohort that I'll be discussing. And compounding it, of course, is caregiver mental health. And this group of young people are also becoming parents. So I think, so this is a group that has very many risk factors, and the interventions around, that we can talk about. And some of our colleagues in JHU that we're collaborating with in dealing with some of these questions on HIV stigma, questions on, quality of parenting and so on. But we are doing something, and structurally, there are guidelines. For example, in Kenya, we are working in, a very, nice, policy. The policy level, we've done very well. We have the Kenya mental health policy, and within the HIV care itself, we have the HIV prevention and treatment guidelines and adolescent package of services guidelines, which provide for very clear mental health care procedures. These are borrowed largely from international consensus. UNAIDS, for example, has, or had, this guideline about 90% of people living with HIV targeting that they be linked to people-centered and context-specific integrated services by last year. I've not looked at the metrics on where we are on this, but I'm sure we are very far from it, achieving that globally. But specifically for mental health services in the HIV care setting, in Kenya, our guidelines do provide for screening, psychotherapy, or what you'd call, mental health first aid for mild to moderate symptoms within the facilities, and trying to make this possible, and referral to mental health specialists for the severe symptoms. So I did mention that I'll be talking about a related study. So some of the things that I'll be talking about from the main study, which is the R01, cannot be fully answered in the R01, but we are attempting to answer them in a related study. I got this K43 2 years ago, about 2 years ago. And we're attempting to answer the specific questions on screening and how we can improve screening, and which is a question of being answered by the R01. So who is doing the screening and who is providing services in the HIV clinic? It's clinicians, adherents and HIV testing counselors, peer educators, youth champions, basically saying, trained clinical personnel, but who are not trained in mental health service delivery, and lay providers. And these are the people who are responsible for screening and making decisions on who gets referred. And in a nutshell, we can say that this, the service is basically can be summed up as inaccessible. A challenge in many facilities, and it's porous. Even where it's available, we do have a lot of gaps. So what are some of those, gaps? Structurally, we are talking about resource gaps. No budget specifically for mental health, very heavy provider workloads in the HIV clinics, lower prioritization of mental health related also to the budgets that are made, lack of privacy in the clinics that makes it difficult to offer mental health services. We do have provider level barriers, lack of interest. Very few providers will say, this is my passion, mental health is my passion, even where they do recognize that it's an important service. What is their capacity? And it is not just capacity in terms of delivery of service. It's simple things like, can you screen? Can you use the screening tool? So the questions of mental health stigma, lack of clarity in provider roles, who does the screening and who is supposed to do the mental health first aid, who should provide the services that the adolescent needs. And these are compounded, of course, by patient level factors. Stigma is a big issue, community level, poverty that limits the options patients have to seek, especially specialist services. And we've talked about, yes, autonomy. When one is having mental illness, can we really say that this person can make decisions appropriately on how they'll seek care? And then there are questions about preferences. And have very few choices when you are offering services in the HIV clinic. So when patients say that I cannot see a specific provider, it further limits the choice that they can have for their services. But there are solutions. And from this study, we found that training is one of the things that the providers keep asking. We need to be trained on how to do simple things like screening and administering the PHQ-9. We can talk about patient support groups that were actually some of the most effective interventions for adolescents and youth that with the funding challenges we're having have actually died with that. There are questions on whether we can use self-screening as potentially scalable intervention strategies for this, and telehealth, and these are being tested by some of our colleagues also at KNH and University of Washington. And now talking about task shifting, which is something that has been discussed for many years and continues to be trialed. And one of the things that you can think about is providing transdiagnostic psychological interventions. And this is, I think, going to be the major point of my discussion. The background, of course, is that psychotherapy has been shown to be very effective in treating depression, and sometimes actually comparable to, for example, using the SSRIs. And this is work in Kisumu by Muthoni and team. And has also been shown to improve treatment adherence for with HIV. So we are interested in transdiagnostic interventions because they're more scalable in our setting than the diagnosis-specific interventions. So if you say, I have an intervention, very good intervention, but I only cannot use it for alcohol abuse, or I can only use it for depressive disorders, so this can only be used for anxiety, it becomes a challenge to train one provider, the same one giving HIV care, on all these many different interventions. So that's one. And the second thing is a lot of times mental health disorders come in a group. So there's a lot of crossover of the disease symptomatology. And, good thing for us, a lot of psychotherapies have been shown to have some transdiagnostic component. And I think this is what PROACT was relying upon. Cognitive behavioral therapy is basically transdiagnostic. And there has been many studies from Mozambique and so on that have shown that even receiving some of the sessions in these very big psychotherapies that have 10, 12, 16 session, packages, receiving just a few of them could still positively impact the mental health of the patients. And so we basically can think about the psychotherapies, the brief psychotherapies like what we have here with PROACT, as potentially also very effective because of some of these studies. And for PROACT, the 5 modules that were selected, making up the name PROACT, were the psychoeducation that basically does normalization and validation, relaxation, this for relieving stress, problem solving to define, problems, behavioral activation, where you reactivate, engagement with activities, and cognitive coping. And this is learning how thoughts, feelings, and behaviors are connected, and they can help you change the impact that has on your life. So we had training, and I'll be discussing the training quite a bit. There are several components. There's a personnel who are trained. We trained about 3 personnel per facility. And some people whom we thought, these are the people who are providing the service. I'll talk a little about that. So the composition that you'll see for our study was the highest number were peer educators. And so this, for the most part, were youth. These are young people who are patients themselves and are given responsibilities to take care of other patients within the facility. There are some facilities who do not necessarily have young people as peer educators. They have an older person living with HIV, and that will be the peer educator. But then we also have, all the other cadres that you see there, the adherence counselors, clinical officers, as I mentioned, from the work from the K43. We also trained psychologists of the local jurisdiction. And these are people whom you could think of as potential supervisors and people who would provide specialist services. And, for PROACT, we had, 5, trainers who then went on to become supervisors for them working directly with the providers. And there was one who is the master supervisor, Mrs. Chumbalelo from Zambia. And, there was the physical training that we first had that was all done at the county level. And then I'm going to talk a little about the virtual coaching and supervision, which I think is the mainstay to the training. I think that would be one of my conclusions. So the length of the training, pretty long, 8 days of in-person training, and I'll talk a little about that, and then 3 months of the virtual coaching before we went on to provide the services to the patient, our clients in the trial. So for the 8 days, in each of the counties, we did 8 days of in-person training, and this is how it was. 1 day of pre-training assessment. There was another day where we talked about competencies, mental health competencies. And this, these are WHO, trainings. Basically, in you can read about equip and equip competencies. And then we had 5 days of specific PROACT training and going, through the the step sheets. We'll talk about the step sheets. And then there was a post-training assessment, again, guided by the WHO equip process. So how did we select the providers to train, the list that you saw? So we basically asked the facility, please give us the 3 people who will have most of the time and have the interest to provide mental health services. And we asked them to think long and hard about that, because the training we knew would be intense. So please don't give us a person who will not find the time to go through the competency or capacity building to be able to offer these services. The training materials did include a few didactics, but a lot of it was delivered through role playing in the PROACT specific sessions, and safety was one of the important topics covered. The pre and post training assessments were done using standardized patient actors and were video recorded. And we did not provide this data, but the expectation is that you'd have experts look at the videos and then grade using the WHO's competency or ENACT. Yeah, this would now be the ENACT assessment. But then we go to the virtual coaching, and this was 3 months, 5 months from when you finished the in-person training. Very, very intense. It was weekly, virtual practice session with one of the trainers, where you covered each of the PROACT modules. You had multiple role plays to internalize the step sheets. And you, when you completed that, and the supervisor, the coach was comfortable, they asked that you recruit a patient from your facility. So they went ahead and did a screening using the PHQ-9, identified an adolescent with symptoms, and then offered service under intense coaching from the trainers, so as to be safe and ensure that the participant or the patient in this case is also receiving the best care possible. And then we went ahead and did an assessment after that with patient actors. So thinking about now the trial itself, we thinking about the people whom we've provided this service in the context of the trial, we have enrolled 600 participants, having screened about 1,719 with a rate of about 35%. This is one of the highest prevalences you've ever found in an HIV care setting, despite knowing that we have a big problem with depressive symptoms. Especially, we rarely get this kind of prevalence, 35% in the clinics, and this has been consistent across many clinics. Some clinics actually have above 50% prevalence of poor mental health and very real risk factors. For example, places that have very high violence rates and in the slum areas, for example, in Nairobi, being major culprits. So we have completed the enrollment of these 600 patients. 300 of them were randomized or in the intervention sites. So this was a cluster randomized. So we did not randomize the participants themselves, but the clinics. So the 300 that were in the intervention site, we have been able to provide at least one PROACT session to close to 90% of them, 260. And about 75% have already completed. And we're hoping that by the end of this month, close to 90% will have completed the interventions. We do not expect to be able to reach everyone who needs it, but we do feel that 90% would be acceptable. So what has been the experience of the providers who delivered this intervention? So of the 45, because we trained 45 providers, several dropped off, about 4 of them during coaching. This was a very interesting thing, and I really like the fact that we did a long coaching period. That is when you get to know the person who came for training, the in-person training, but was never going to deliver the intervention. They're so busy, so basically the training have helped them, but was not very useful for the implementation. And out of those who went ahead to provide services after the coaching period under supervision, our at least 2/3, at least 2/3 have served at least 5 participants, which means that they've done at least 20 sessions, which I think is good enough for you to start talking about competency in providing the services. There's one provider who's seen 18 participants with very high delivery of this intervention. So one of the cornerstones of the intervention was or is support supervision. And the support supervision is accompanied by a fidelity assessment. So we have pre-sessions and post-session support supervision with a supervisor discussing, so what did you do in your last session, and did you follow the step sheet and so on? The scoring criteria for fidelity, assessment, that is adherence and competency, and also discussing your next session for this participant. When they come back, what are you going to discuss, and how you're going to go, how will you go through the step sheets for them? What we've seen, what you'll see with the score progression for fidelity is that by the time you're getting to the fourth session, we were very close to hitting a score of 4 out of 6, which is regarded by the mental health experts as a very good score for people who are basically lay providers. And we've had to put in some strategies to specifically targeting implementation climate. They have their other usefulness. For example, site entry, when you're talking about county and facility engagement, but really the target is improving implementation climate, easy buy-in and support within the county, which is the local, unit, administrative unit, and also in the facility. Thinking about, getting to know how your study will be affected by routine issues, for example, layoff. This has been a massive, massive problem, layoffs and transfers of providers across sites, some of them because of the funding issues we had with USAID last year. And so this close county engagement has really been, of use to us to get that done. Then continuous quality improvement sessions, which, have been key, thinking about the support that the person who is delivering PROACT, this was in intervention sites, the kind of support that they're receiving. Also from, the environment that they are in, people who are not delivering the intervention, but are important for them. And these were 1-hour sessions, and we can discuss the plan to study ACT cycles. So what are some of the lessons learned? Of course, strong local team engagement, as I've said, that's also important. Post-training practice and supervision, this really is the cornerstone, task shifting. I think training, when people write, my strategy is training, and many times, whatever strategy you take, or decide, this is the one that I'm going to use for implementing my intervention, training will be part of it. But without a lot of evidence, but I'm sure there are that my colleagues can produce on this, but one of the things that has been very clear is that the practice and supervision really is what makes the difference between delivering an intervention and not really patients not really getting what they need. So this has been very, very key, and so I think so some of the things that we'll design with keenness. Probably could shorten the didactic training and case studies. Could think about pre-recorded videos, tools that people can do for the training. But I think, shorten that didactic, give more time to more useful training, and think about language adaptation, especially with because some providers will be providing this service not in English, and that has not been an infrequent request, that we need the step sheets and thinking about the whole intervention in the local languages. So there is the intense practice and a need to start early. So we had about 3 to 5 months, which was good because, of course, we were able to weed out providers who may not be able to offer the service. But at the same time, of course, there was a challenge of, the person may have forgotten what they were supposed to do by the time you're starting the study. So 3 months was a sweet spot for many people. 5 months was a longer period. The one-on-one coaching and supervision, again, I think I'm overemphasizing this, but the supervision that has gone on over the last 2 years allows for individualized, paced, and more natural learning. There is the option of doing group supervision that we do not have experience on for this study, but the people in the project who do have some experience with it. It reduced need coordinate with other very busy colleagues, making for supervision to be a little less tiresome for the providers. But of course, it diminished teamwork. And this is something that you may want to consider, that once in a while to bring the people together for group supervision and increase interpersonal learning opportunities. The providers have said, and we're going to measure this, but they've already said that, have increased confidence in delivering mental health services now, especially with difficult patients, especially when you're thinking about patients who are not achieving HIV care milestones. And then thinking about incorporating sections of the interventions in their own daily work, in their own lives, with their own children, especially things about cognitive coping that they say they incorporated in their own work. Yeah, so I end there with acknowledging the adolescents and youth in the 30 HIV clinics, in the PROACT project, the providers, enormous support from the county and sub-county leadership teams, Ministry of Health in Kenya, and the PROACT team. And a special mention again to Dr. Nelima, Dr. Maganga, and Jeffrey for helping prepare this talk. This is a big collaborative group with all these institutions providing expertise for this project. And this was in a stakeholder workshop that we had at the beginning of the project. And yeah, we continue to keep these people in the implementation of the study. I'm happy to welcome Christian.
Thank you so much for that really wonderful presentation. And I love ending on this image because it is so emblematic of just how many people it takes, right? And just how much collaboration and coordination a big project like this takes. So thank you so much for sharing all of this. And we'll start with a little conversation between Dr. Mugo and myself, and then we will open up for your questions online. So please go ahead. If some of you already been entering questions, please continue to do so. We'll make sure we save time to have some audience questions as well at the end. But just to get us started, and Cyrus, you've talked about fidelity, and I just think it's one of those things that's really so important and also so challenging to assess really well. And I was wondering if you could just take a minute to sort of expand upon it a little bit more and tell us a little bit about like what some of the pros and cons were, or what considerations you had, and how you did fidelity, or any sort of lessons learned around this.
Yeah. Thanks for that. So yeah, fidelity was interesting, and I was not very familiar with it. As an implementation scientist, you always want to think about fidelity in implementation. But I didn't have any expertise in this. But we were very lucky to have Dr. Shannon Dorsey, who is an expert in fidelity assessment, and already having developed these tools. So, of course, you have several options. You can have an expert directly observe a session, and that's an option you could use. Very expensive, of course, intrusive. And in the HIV care setting, you probably don't want to go with that. And that was ruled out quickly. And so you're left with other tools. You could do recordings, and you'll have to build confidence with the patient, especially that. And also the provider, that the recording will not find its way to YouTube. I think that is always the biggest challenge, that they'll find their session somewhere when it's video recorded. So that's another one that has been used. We've used that when you are doing work on training in PrEP delivery and so on. But for mental health services, probably this one that we are still not keen on going for. And so you are left with self-report, and not very nice too. You're thinking, everyone has a bias to say that they did the things that they say they, you're expecting them to do. But you enhance, and this is, the work that Dr. Dorsey has done, enhancing the self-report, so that you're dealing with the self-report, not someone just saying, I ticking a box, but going through this session with the supervisor and saying, within an hour session, this is how I went through the step sheet, and they relieve the moments during their session. Very intense, takes quite a bit, and I'm very sure it will contribute quite a bit to the cost of the intervention. We are going to do that math, but I think it creates a sweet spot on not being intrusive, and at the same time providing some objectivity, because this is now done by the supervisor. And they're the ones who make a decision on, from what you've told me, this is the adherence level that you are at. And from what you've told me, this is the competency level that you're at. Yeah.
Yeah, thank you. And it kind of leads me into my next question, which again, I know some of your really key takeaways here are about the supervision model and the importance of supervision. And, what you all have built here is a very intensive supervision model, which is, clearly a real strength. It's also, comes with strengths like trade-offs, right? Like there's also some trade-offs when we think about sort of the resources and the model around supervision. And again, I was just wondering if you could talk us through a little bit some of your like just a chance to expand upon what you've already talked about.
Mhm.
Some of the rationale or some of the struggles or and a little more about the successes of sort of that model and where you are now that you've been doing the study for a while and thinking about the model of supervision.
Yeah. Yes. So we've had a long debate on support supervision, and the strain, honestly, is between the mental health experts and the implementation scientists. So me pitted on one side with my implementation science colleagues, and on the other side, we've got the mental health experts. The mental health experts want a very intense support supervision because they do understand that for you to provide this service well, which in many times is a life-saving, you're talking about safety and so on. It's life-saving intervention. And then you have the implementation scientist on the other side saying, this does not look like it can be scaled. This kind of intensity cannot be scaled. So there has been a long, debate within our team. But I think at the end of the day, we all appreciate it. We just need to do it and provide the cost for it. What we did was settle on about 30 minutes to prepare for a session. And then, a provider will provide the session and then 30 minutes after. And this was very, very useful. I think it was 1 hour. They were doing 1 hour before when we were starting. And I think it went down to 30 minutes by the time, we are now at the tail end before the session and 30 minutes after the session. It's so critical. This is counterbalanced with the investment you have with the training. And I think you could probably reduce the training and the cost within the training to ensure that you have resources left for support supervision. And I think moving forward, that's one of the things that, we can have in mind. Thinking about scaling, but at the same time ensuring that services, especially task-shifted services that are so critical, in this case, our population had about 15% of our adolescents having suicidal ideation. So this was a very important component because it was life-saving. Yeah, so the strain, I think, has been there for 2 years. And I think we're going to write some good papers about the model that we've applied and also cost it to ensure that people understand the balance of it. And I think, I was also looking at the questions that Judy Bass asked. It's is it different? Actually not sure, but I've visited some posters during the DNI conference, I think 2 years ago, and for the adult services, the same thing was reported. We need very strong support supervision, but at the same time, we need models that can be scaled. Yeah.
Great, thanks. And as we think about sort of this, well, I'll do one more question for me, then I'll move on to all audience questions. I but I'm selfish and I want to ask this. Um, I think when we talk about who the provider is, and in this case, right, talking about working with providers within clinic settings, the key layer there that we have to consider and think about is the clinics themselves, which are these little like microorganisms with their own sort of institutions and structures and rules. And I imagine there's probably a lot of heterogeneity across the clinics that you work in, and the like engagement of those clinics itself, right? It's like logistical, it's political, and I'm just wondering if you could talk a little bit more about. It sounds like you guys have been really successful in this, and what strategies you found successful in sort of working with and engaging clinics in such meaningful ways that are probably pretty heterogeneous.
Yeah. Yeah. So, Dr. Vincent Maganga, the study coordinator, I know can give a whole speech about the engagement. It's been very rigorous for this project. Um, you know, Very many meetings with, the top health department at the local level, leadership. I think we've done maybe one or two meetings at least every year. And one of the things that we had built in was the continuous quality improvement. I think those have meetings, and sometimes you could see them as potentially an important integral part, strategy that comes with the intervention itself. You want to be self-improving within the site and adapting as you go, the implementation as you go along. So I think that has been an important component. Also having, research team that are dedicated to the role of engagement. And I think this is the role that Vincent Maganga has done very, very well. Whether it's phone calls to heads of the health departments, the county directors, or to allied people, their partners, USAID partners, CDC partners, and so on, who are funding a lot of this work. We went through a very difficult period last year because of the HIV funding that is across, all countries basically. And the biggest question was, we've trained and gone through a very intense training for a provider. The investment was massive, many months of training. Getting a new provider to train within the period of the study was not possible. And so if we had one provider laid off that we had trained, we had to get them to a site, either in the same site that we were offering services, or the study had to take up the cost of keeping that provider within the site to ensure that the service and the study continues. So that has been an important part of the study. And I think, if also, one of the things we do not anticipate is very high cost of people or doing the training of a new provider. I think that's one thing that I'd never thought in my mind that would be that expensive. But we've received a lot of support from the leadership, whether it's a ministry or county or facility level for this.
Great, thank you. Um, yeah, it's there's so many layers, and I think just it's very, I mean, the changing, like we think about structurally sort of the outside layer of all these major funding changes that your project has worked through. It's really quite remarkable, the work that you all have been able to continue to do and to iterate and innovate within such a changing landscape. A quick clarifying question from one of our audience members, I think you were just getting at, but they wanted to clarify if the provider was being deployed by the government and funded by the government or funded by the study. And it sounds like perhaps it was maybe shifted or changed a little bit depending on funding situations and if people left. But can you clarify, Cyrus?
Yeah. So this were all government, you know, employees within the site. Some of them were supported by, for example, USAID, but they were basically government. What has happened is, where there have been layoffs of a trained provider, we've had to keep them on as a study and take up that cost of keeping them on until the end of when we stop providing the services.
Yeah, makes sense. One of the questions our audience member had was more about the psychotherapy itself, and I think you explained, probably after this question was asked, very nicely the transdiagnostic model and sort of theoretical approach and why transdiagnostic models are so useful in this context. They also sort of had this question around your experience of, if you think psychotherapy, like a transdiagnostic therapy, for instance, can be sort of universalized, or were there sort of localized or like decolonial aspects that you were able to bring in or felt were necessary to bring in? If you could talk a little bit about sort of the adaptation to the context a little bit more.
Yeah. So I think the work let me start this way. So this is cognitive behavioral therapy that has very good evidentiary base in high income countries and also in low income countries. So a lot of the work that has been done, whether it's in Kenya, Tanzania, Mozambique, a lot of African countries, for context, with a full CBT, and trauma-focused CBT that Dr. Dossi has done in team. I think the evidence is there that it's very effective. Now, the question, of course, is the brief interventions, the brief CBT interventions, and they're many. I know some of us have heard about the friendship bench. It's not very different. They're also CBT based. They may not be, for example, I don't know whether the friendship bench now has cognitive coping as part of its battery, but I think it's just a selection of the different modules. If we talk about PM plus, problem solving plus, that is endorsed by WHO, not also very different from PROACT. It may not have some components that PROACT has, but otherwise they're all CBT based. And is there some decolonial work that has been done? I want to believe that that is work that preceded our trial. Pamela Collins, Muthoni were involved heavily in, trialing, developing and trialing and piloting, the PROACT, intervention as, the brief intervention among youth in Nairobi during COVID. And so I'm sure that adaptation work was done. We also had adaptation to think about now the HIV care setting specifically, but for us, I don't think we, delve so much in thinking about how different it is from what is presented in the Western world.
Yeah, no, I think that's great, and it is really interesting sometimes when we look across many of these models, what they share in common, in addition to sort of how things are shaped for one particular context or one particular population, or but often some of these key components being very similar is a great point. Maybe dovetailing off that question, Dr. Collins, your collaborator, had a question about community supports as well. And so, in addition to the product intervention itself, how do you think or should HIV care integrate mental health supports outside of the treatment setting? Is there sort of a role or a place for thinking about more informal or like community-based supports? What have you found or seen to be really important in your work?
So yeah, absolutely. This is something that providers have asked so many times, and adolescents, they want us to think about mental health services outside of the facility. It's very challenging thinking about the community component. And we've been thinking about it. We've had several grants that we've written. And I think they've been, the funding has been challenging because even describing it is thinking about the feasibility itself is quite difficult. So we do have, cadres now that are the community level, and there are people who are using those cadres to think about delivery of mental health services, but they're meeting the same challenges that we are facing in the facility, where we are saying heavy provider workload. We need to do task shifting within the facility. When you go to the community, the person who is being given all the work again is the community health provider, who unfortunately has been given all the roles. They're the ones who are being expected to enroll people to insurance. They're people who are expected to do cancer screening, high blood pressure screening, and so on. So mental health is also being added on top of this. And so it's a challenge. We also think about the school, because the school has very good infrastructure for, with school health nurses, teachers, very highly literate, professionals there that can take up some of this work. And so that I think actually has higher feasibility than community delivery. But I think we'll see. Among the grants that we are writing, hopefully we get one that we can try community delivered or school delivered interventions, and we see whether we can have the same success as we're having with the facilities.
Yeah, great. I think sort of perhaps the flip side of this, and one of my favorite topics to talk about, one of our audience members was wondering about how stigma around mental health, but I also imagine around HIV, how you saw that affecting, or if you saw it affecting recruitment or engagement or retention in the study. And I would actually say both from the perspective of the clients, the people coming in to receive the care, the participants themselves, but also from the providers, who, if that was in any kind of concern or consideration in how you were engaging and working with the providers themselves.
Yeah. Yeah, thanks for that. So yes, we are measuring. I think we made a decision very early on to measure mental health stigma systematically among adolescents. We're not doing the same for providers, although now, we have one of JHU's, PhD folks before looking at mental health stigma and the impact it's had, and also thinking about interventions and how PROACT, for example, could be strengthened with anti-stigma components. So did it influence recruitment? Probably did. We did have a big proportion that was eligible. But then let me retract that. The proportion that was eligible but was not enrolled was actually small. It was just about 5% of the total that was enrolled. So I can't infer that the stigma was a big deal or a big issue. Mental health stigma was a big issue with this. But I think we know that mental health stigma is a problem within our settings. The challenge has been that we've not been doing any assessments for mental health stigma, while we've been doing the same for HIV stigma, which is a big issue. Only recently have we started using the tools, the tools that can objectively collect data on mental health stigma. So yeah.
Oh, that'll be really interesting to see how as you collect that data, what that looks like and what you find. I'll be very curious to stay tuned in to hear. I think thinking again sort of about the providers, and sort of asked you about stigma a minute ago, but can you just talk a little bit in general about like what as you try to encourage providers to sort of enroll or like to learn about PROACT, um, what was that like? What were those procedures and processes like? How did you sort of, were people really eager to join? Were they reluctant? What kinds of things did you have to do to sort of recruit the providers in? Or I think is the question that we have from the audience.
Yeah. So we were very lucky with recruitment of providers. They're already very motivated. And mental health is considered a very important issue in the HIV care setting. I think with the integrated systems where we are not necessarily providing HIV services in exclusive, HIV clinics, where we are going to be having this work done in outpatient departments. We may see something different about the motivation of providers to offer the service. But within the HIV clinic, this is actually something that you don't have to motivate a lot of providers for. The biggest challenge is workload. That is the biggest challenge. And so you're going to get your peer educator, very eager to offer the service. You're going to get your clinician, but your clinician is going to say, I really want to offer it, but I'm very busy. So I can only do the screening and I have to leave the rest for someone else. Your adherence counselor, who is traditionally considered a mental health professional within the HIV clinic setting, they will be very eager to get the skills and start offering the new service. And this is what they've said, given us a new arsenal to be able to help our patients. And some of the experiences, if I could just say, has been phenomenal. Providers telling us we are now receiving clients from other facilities who've heard that we offer services, mental health services. And so we are able to offer this service to people who are not even being targeted by the study. So it's in one of those studies where we do not have to do so much to incentivize the providers to offer the service.
Yeah, that's really great to hear. And workload is always a struggle everywhere. But that kind of demand is really exciting to hear about. And I think we have to sort of sadly, because I think we could keep talking to you for a long time about this, Cyrus.
Yeah.
Um, we have to sort of wrap up in a second. I do just want to give you one brief minute to say, I know we touched on Dr. Bass's question about so the difference of supervision between young adults and young adults and adolescents and adults. And in general, I know like the research on youth and adolescents and towards global mental health is so much smaller than the research on adults. Any sort of last things you want to say about working with that population, work with adolescents, young adults, key things for people to remember or know that may not be the population they work with on the call.
Yeah, yeah. So yes, I very little experience with adults myself. I've always found it, you know, interesting working with young children and adolescents and, the youth. But occasionally, I'll be in, discussions about, our adults. And, you know, the biggest issue for adolescents, of course, is access. And these are interesting for an implementation scientist. These are interesting questions. For adults, that may not actually be the biggest issue because the adult is probably has the agency to get themselves to clinic and speak for themselves and say, I'm experiencing this challenge. It's not always the case, but that may not be the biggest issue. So for the provision of services, I think the competency of the provider, of course, generally, I think is a big issue. But of course, the adolescents come with the added complexity. You've got to think about their school schedule. It's probably 3 months before you're able to see them for the next session. It's not the same for an adult whom you can schedule weekly sessions. For adolescents, you will not manage to do that. And you will not discuss suicide the same way you're going to discuss suicide with the adult. So I can imagine that provision of these services, there is a pediatric, there is an adolescent provider whom many people like, even adults like those providers because they're very sensitive to a lot of these things. And of course, there's the adult provider whom even the adults don't like because they're not sensitive to a lot of these things. So it's a challenge. And we're experiencing, whether it's in sickle cell care, whether it's in cancer care, whether it's in HIV, of course, there's that big difference between the pediatric adolescent provider and physician, the adult provider, and it manifests in the outcomes that we see when you're doing transition, especially of adolescents to adult care. Yeah.
Yeah, those are such important points. Thank you so much. I just want to, in our last minute, take a second to say thank you so much, Dr. Mugo, for sharing your time, your insights, your expertise today. It was really thought-provoking, and we're really grateful to have your contribution to this series. And thank you all to all the participants for joining us and engaging in this conversation. It's through these kinds of shared spaces that we continue to learn from one another and advance more equitable and context-responsive mental health care globally. We also really hope you'll join us for our next session in the Who the Provider Is series, which takes place on June 10th. We'll be joined by Professor Rochelle Burgess from the University College of London. And thank you again for being a part of this growing global community. We look forward to continuing the conversation with you. And just one more really big thanks to Dr. Mugo for sharing your time and your expertise today. Hope everyone has a wonderful rest of your day and a good rest of your week.